welcome to Friday Facts, everyone. So excited. Welcome to February. Welcome to Black History Month. We have a wonderful month of activities here. We have two great Friday Facts speakers. We have Kenya Servia today, and we're going to learn all about Kenya and her work as the Business Development and Outreach Specialist for the North Carolina Health Information Exchange Authority. That's a lot of fun words, and we're going to learn about what all of those mean. So very excited today. Next Friday, we have our February monthly meeting. We are going to be focusing on Black History Month. We really try to focus on Black history all months of the year. So it is always weird that there's one month, but we wanted to be very intentional. And Mary Williams Stover is going to be joining us talking about the Center for Black Health and Equity. So that is February 16th from 11 to 1. And then at the end of the month, the fourth Friday of the month, February 23rd, we're going to have Dr. Daryl Davis Fulmer. Dr. Fulmer is part of the North Carolina Retired Governmental Employees Association. She also helps to run part of the North Carolina All Ages and All Stages. Both she and Mary Williams Stover are active with our friends with the North Carolina Coalition on Aging, and they run their the BIPOC, Black, Indigenous, People of Color Health Equity Committee. So lots of that. And I'll give you a little bit of a teaser. Dr. Fulmer's family, she grew up with Martin Luther King Jr., was a family friend.
Wow.
And so she has a lot to share with us about growing up within the civil rights movement. And I learned that and I was like, wow. So anyway, we have a whole month of exciting activities, but really so excited to have you all here. And Kenya, you've been a part of the coalition for a while now, and yet there's so much we need to know. So I've selfishly been really looking forward to this because I know there's so much I want to know about you, and really the health information exchange I don't know enough about. So welcome, Kenya Servia.
Well, thank you so much for the warm welcome. I do have one point of clarification to make just really quickly. I
Clarify
am
me
not
away. I
the,
always need to be clarified.
yes, well, I'm not the business development outreach specialist, but I am one of four. We have Luke Keeler, um, Kimberly, oh gosh, Webster, and Adonica Rowland are our other three business development outreach specialists. So I wanted to make sure to give them their due diligence, as well as to just let anyone know that if they have questions, I am not the sole owner of all the information at the Health Information Exchange. There's
Oh,
plenty of people available to help.
that is fine. We're just going to put you in charge of all health information for all of North Carolinians. Here we go. It's Go Big
Okay.
Friday, and we're going to put you in charge of everything. And really quick, as you were talking about your colleagues, our coalition members, you've already started to sign in. Please feel free to sign in, add your name and your organizations in the chat. And I have a bunch of questions, but I don't want to do too much. So feel free to share any questions you have along the way, and I'll pay attention. All right, Kenya, before you get into the slides, we need to know a little bit about you. You know that's part of our Friday Facts routine.
Okay.
Tell us about
All
your
right.
background. What kind of shaped your fascination with all things information services and IT? Where do you come from?
Well, I come from a little small town called Bayboro, North Carolina, which is where I'm sitting currently. And really what sparked my, not just my love for um, information technology, but just my love for the state of North Carolina and the citizens of North Carolina. It's my innate desire to help people in any way I can, which is what I do as a business development and outreach specialist, is I help providers understand what the health information exchange is. I help to alleviate the anxiety and worries that they have about the legislative mandate and help to answer their questions so that they can participate and be compliant with this process without feeling or adding any additional burden to their day-to-day work stream.
I love it. Well, I was going to ask even more questions, but I see that you have a PowerPoint, and I'm just going to let you do the PowerPoint because I have a feeling even when I look at the questions, those were a bunch of the questions I was going to ask you. So,
Yeah.
Kenya, I'd love to keep talking about you, and I do want to get back to you and some of your personal connections to the coalition. But first, tell us about the North Carolina Health Information Exchange Authority.
All
Wow.
right. So um, I'll skip ahead just a little bit because I want to talk about, and I'm not sure if there's a little overlap at the top of my screen, so I can never tell if it's blocking the part of the slides. But there is we are one of the newer state agencies that was developed by the North Carolina General Assembly with really the sole purpose of helping to modernize the state health information exchange, and that was when it was branded NC Health Connects. And we are part of the Department of Information Technologies Data Division, formerly known as the Government Data Analytics Center. We're governed by a 12-member advisory board. So we have Secretary Kinsey with the Department of Health and Human Services. We have our own Department of Information Technology Secretary, as well as our GDAC Director. Those are our a few of our members. We have a public-private partnership with SAS Institute, which is in Cary, North Carolina. And they are our technology partners. We work very closely with them to because a lot of our providers are small solo providers. They don't have their own technology teams or departments, so they need just someone to kind of work that or lift that part of the mandate. So SAS does the building of the integration from the EHR or the electronic health record to the health information exchange so that we get those clinical and demographic data elements that are shared to different providers or available within the health information exchange. And that was something from my previous slide, but I wanted to first explain who we are at the HIEA.
Great. I was like, okay. All right, well, I'll let you keep going and folks keep joining us. This is great. And I was like, oh, I didn't realize you were connected to SAS. All right, I'm not going to ask follow-up questions until you do the whole presentation.
Okay, and I'm going to back up just a little bit because I do want to just clarify what exactly a health information exchange is. A lot of people currently are still on paper records and they share their information. If there's a records request, they'll either mail in a digital copy or they'll mail in paper charts for a patient, or a patient will have to stop by and get those records and take them to another provider if they're coordinating care between one provider and another. So with the health information exchange, it allows those providers that have an authorized relationship with us to share that health related information, both clinical and demographic data elements, electronically. And so that way, and it meets the HIPAA compliant as well as other mandates. So what that does is it allows them to not have to do all that legwork to make sure that their health information is shared among other providers. So then those providers can communicate with each other and coordinate care with that patient in mind. And so those benefits of that health information exchange is that healthcare provider has that view of the full picture of their patient's health care. They get ambulatory visits, hospitalizations, medications. And while I'm, on that, North Carolina is one of the first health information exchanges to integrate pharmacy data within our health information exchange. So we're literally trailing the way in health information across the nation. You get reduction in valuable staff time, hunting down faxes and making phone calls. You get timely and accurate medication reconciliation, improved and more accurate and timely medication reconciliation, and you get access to test results, which help reduce the costly duplicative testing and gaps in treatment. So there's a couple of ways that providers send us their data, but primarily I like to talk about the unidirectional connection because that's what most of our providers have. And that's a one-way connection where providers, again, their EHR, electronic health record, sends the data, they build that bridge, that integration, and they send clinical and demographic data on their behalf. And then for our providers that have what's known as a full participation agreement, they then can log in from a web browser, any search engine with the exception of Internet Explorer, and they can, from their phones, a tablet, iPad, or their desktop, laptop, whatever they have, they can search their patient's longitudinal medical record and then view the data that's populated within NC Health Connects. So another one of those integrations we have, it's called bidirectionality. Many of our providers are very busy. They don't have the ability to log into multiple systems. So with bidirectionality and that full participation agreement, if their EHR has that technical capability, they can build a second bridge, a second integration back from the health information exchange to their EHR. So now when they're working in either, Athena or Epic or whatever EHR they're using, they can now view the health information exchange data directly within their electronic health record. And there's many providers, thousands of providers across the state that are connected to Health Information Exchange. And if there are patients here or other clinicians, and you want to know who's participating around the state of North Carolina, you have the ability to search on our website. We have a See Who's Connected section where you can view it in either a table format or a map, and you can search by provider type or the name of the practice, and it'll show you where basically they're located across the state. I'm not going to go too much more into the mandate because I think I've discussed that. And again, there is another form of participation agreement that I did not speak about earlier, and that's the submit only. And the key thing about the submit only participation agreement is those providers are not allowed to, because their participation agreement does not have a business associate agreement within that contract. They're not allowed to send data that's not associated with state funds, because essentially what the mandate is requiring is that providers who receive any funding from the state, whether it be Medicaid or state health plan, or if there's other revenue, such as a grant from the Office of Rural Health to provide health care, then those providers are mandated to connect unless they've been called out by legislation. So with that submit only participation agreement, they can only send state funded data. They have to make sure their EHR vendor has the capability or the ability to filter by payer, and they don't get the added benefit of using our services, which is the main reason why many providers sign that full participation agreement, is because they do want access to that patient record. And with that, Heather, I saw some questions come in. And so if you want to stop and ask a couple questions, I'll stop here. This is a good point.
Oh, okay. All right. Well, I am seeing your colleague Luke has been actually posting information. Right? So I think you're good to keep going. I mean, I have
Oh,
questions, but
excellent.
Luke is
Okay,
got your back behind the scenes and is showing about how to get access to the map and the website.
Sally.
And I know for me, I'm still wrapping my mind around this. And I tried to do prep, and I'm still, so people choose to participate in this and then decide what level do they want to give information or receive information. It sounds like, you know,
Okay, so that's great. So let me just clarify. So they legislatively, the General Assembly is mandating that they participate if they receive state funding.
yes, I realized
So,
that was my word
um,
choose.
s-
So they have to
but
do
they
it
do
if they receive.
choose. They have to participate. So there's a contract that they have to sign, a participation agreement agreeing that they'll send certain clinical and demographic data elements. But exactly correct. It is a choice whether or not those providers decide to log into our web-based clinical portal or utilize our services. And which is great thing that you pointed out that Luke's here, because that is primarily what we do with the business development and outreach team. Is we are tasked with increasing adoption and utilization, because it is a choice. We want providers to know the benefits of health information exchange so that they can make the most, or the best choice for their practice. So that's a
Mhm.
great point, Heather.
And one other question that I want you to be able to keep going on, because both with time and just so people get the fullness of information,
Yeah.
how is provider determined? This makes me think back to years ago with the Department of Health and Human Services and the Division of Aging and Adult Services, all the world I used to love to participate in
Hmm.
as a community member. And there was an effort to try to get more community organizations. So the services provided through our Department on Aging's, locally, Meals on Wheels, other
Hmm.
providers that would connect more to the social determinants of health as opposed to healthcare providers. Oh, you're laughing. I've
But
tipped on something.
no,
Are they
I'm not
part of
laughing.
this
I
or
think
no?
but I think that's you bring a good point because okay, so there are the mandated providers that are, participating because of statute, and that's how statute determines what's considered actually a healthcare provider, and they have it written out really nicely in the statute, and you had a link to that in the invitation, so anyone who wants more clarity about what exactly that's considered. But when you mention social determinants of health, Meals on Wheels, perfect example. My mom gets Meals on Wheels, and um, other services that are available in the community, housing and things of that nature. We have the ability, if a provider is not mandated to connect and they are still able through HIPAA for treatment, payment, and healthcare operations, um, are able to utilize the health information exchange, they can still sign a full participation agreement and utilize the service as a voluntary provider. But again, there's a 52-page contract, so we're not just giving anyone who wants access to the health information exchange, but if there are a designated, they're an agency that meets those requirements as outlined by HIPAA, they could still request access even if they're not required to.
Okay, well, that's great. I know this was a huge issue years ago with the no wrong door and everyone being able to share information to support an individual and their family. And the big pushback came, well, how do you share information in a protected way? And how do you share just the right amount of information? Not everyone needs to know everybody's business. So, all right, well, so I'm all like, this is the
And you
beginning of a
give a
lot
good
of questions
segue.
for us. And Luke really is awesome. He is sending links to other documents. So that's
Amen.
great. So keep
Yeah,
going with
and
your slides, I realize.
okay. So you brought up a good point, and I'm gonna skip here just for a second because um, each practice, when they are completing their participation agreement, they have to designate a participant account administrator. So you mentioned the no wrong door. So what the participant account administrator does, they're in the practice, they're boots on the ground. They know who needs access and what level of access, because not everyone needs the full longitudinal medical record. Not everyone needs all the clinical data. Some people at check-in just need the demographic information in order to make sure they have the right address and the right phone number and details such as that. So that participant account administrator not only helps to assign role-based access, but they keep us updated when there's changes at their practice. They liaison with us between their EHR and SAS and update information such as that. So we have a in-house person at each practice who works specifically with us at the Health Information Exchange to make sure that their practice is not only following, their internal practices, but the guidelines of the Health Information Exchange. We have the PAA reference guide linked here. Um, and I'm not sure where I am on time, but I do want to make sure that I mentioned that we do have upcoming training, and that's one of my later slides, but I want to
Yeah, you're good. You
mention that
have 11 minutes. You're good.
we let's see what I want to clarify a couple of things too before I go any further, is that there's a misconception with a lot of providers about regarding the type of data. So I wanted to share this particular slide and not necessarily rush through this because there are both demographic and clinical data elements that we ask or request that providers send to us. Of course, we would like for them to send us the most robust data set possible, but we realize that some EHRs have limitations. Not all providers capture the same data within their practice or their EHR. And we have a designated set of analysts on our team that are really working with patient matching, identity verification, and other elements to make sure that the EHRs are sending us, again, robust data that's really going to be usable when it comes to other providers searching within the HIE. So here you have the different patient level of data, the demographics here that we're trying to collect from the practices. Then you have the different levels of the CCD, or the continuity of care documents. And then it gets more granular into those more detailed clinical elements that we're requesting from patients. And then I wanted to include this because often I work with the behavioral health community, and I wanted to plug that in June, on June 21st to be exact, we'll be having our behavioral health IDD working group, and that'll be an opportunity for behavioral health and IDD providers specifically to come and discuss issues that they are having regarding participating in health information exchange, or to offer suggestions or feedback about their experiences of having been participants with the health information exchange. So one key thing that I like to note here is that we don't accept psychotherapy notes from behavioral health providers. That was a key area of concern that many behavioral health providers have expressed with us, and we have never accepted that form of data, but I always, at any opportunity I get, I like to clarify that point if I have an opportunity. And neither do we accept 42 CFR Part 2 substance use disorder data. So if a provider, let's say for instance, if it's a substance use disorder facility and all they do is 100% substance use disorder at their practice, they are not required to participate in health information exchange. But with a full participation agreement, a substance use disorder facility can sign that full participation agreement to have access to the health information, their longitudinal medical record for their patients, and use that information for treatment, payment, and healthcare operation purposes. But again, they don't have to have an EHR and do that, build that integration to send any data to us, but they'll still be able to access and view data.
I
And that
got
works the same for any of our other voluntary providers. They don't have to have an EHR, which for many small providers, that's a exorbitant expense, so they don't want to do that. So that's the great benefit of having that full participation agreement as a voluntary provider.
Well, and Kenya, I'm going
Did
to
you say
interrupt.
something, Heather?
Yeah, I'm interrupting real quick just because, and that's fascinating. That answered some of my questions I had about privacy. We have a great question from the
Mhm.
fabulous Mayor Angela Caraway, who is on here, and she asked in the chat line two questions. She says, just so I'm clear, are you indicating that the person or the health institutions are mandated to sign up with the exchange? That's the first question. And that's a
Okay.
good one. And then the next one is the map shows a number of 34 providers in her county of Anson. Can you explain that number, as we don't have 34 health institutions? So that's a good
Okay.
on-the-ground explanation question.
So, so the providers who are receive state funding to provide health care, those are individual health care providers, are required. Now, if your organization signs the participation agreement, then that organization covers all the providers that work at their practice. So it could be either individual if you're a solo provider, but if you have an organization, then your participation agreement covers the providers that work there. So let's say we get a participation agreement from a hospital, and hospitals have, they could have 50 or 60 other facilities. They can list all those participating entities, and their business associate agreement will cover not only their hospital, but the other entities that are part of their agreement. So I hope that answered that question. Now, with regards to the 34 practices that you see for Anson, even though a provider may not be in the demographic area of Anson, if they receive funding to, or they have patients from Anson to cross over, or they have the ability to, see Anson County patients, that'll still be considered as they're covering Anson County. I don't know if I kind of fumbled that, but I hope that made
So
that
if
clear.
you're so here I'm in Chapel Hill, UNC Chapel Hill, UNC Health
Uh-huh.
System sees
Yep.
people from all 100 counties. So would that count as
Yep.
one of the dots in Anson, even though it's here in Chapel Hill, because it would see people?
Correct.
Is that why?
That's very correct.
Oh,
Just
all
like
right.
in Pamlico County, we don't have a hospital or a health system. We have a health system, but not a hospital. So our nearest hospital would be in New Bern. So that would be considered a hospital for Pamlico County.
Great. And here's another question, and it goes into what I know I'm really interested in as well, because I know there's been some complications. Vicky Dougherty asks, are advanced directives easily accessible if they are part of the EHR?
Wow, that is a great question.
That's a
And
great
at this time,
question.
very great question. And at this time, they are not a part of that. We still are, we have had many talks with the Secretary of State's office to try to incorporate advanced directive data. And that is not yet a part of it, but we are hoping at some point there will be legislation that will allow there to be some funding and allow there to be, a body designated to work to really establish that connection. That has been something that's been on our roadmap for some time now. I've sat on several meetings and committees for that, and I as a caregiver full time, I 100% look forward to the day when I don't have to make sure that every time I travel that I have my power of attorney and different paperwork with me when I'm going somewhere.
And Kenya, isn't that the reason why I'm so passionately involved in the coalition? That's part of our, if I understand correctly, that's part of the bill that we have that's right now kind of stuck in the Senate because it not only is it the changing from two witnesses or a notary, but it allows
Mhm.
for the electronic storing and sharing. So once that's passed, it would also allow, correct? That's why we're working so hard. This is part of what I'm telling people. So make sure I'm not a liar. Make an honest woman out
Well,
of me, Kenya.
I'm not exactly sure kind of everything about the statute, and I'm not sure if Christy's here who can clarify it, but um at some point I'm hoping that it's going to be the electronic sharing of advanced directives is going to be a statewide um policy or mandate at some point.
Well, and great that we can work together
Yeah.
on that. So, if you have a few more slides, I want to, I we have, well, we can go over for a few minutes. Tell me if you have more slides that are important to share in terms of telling the story of the HIEA.
Well, I do want to make mention of one of our services. I don't have time to talk about them here, but one of the key things for tailored care management is being able to have admission, discharge, and transfer fees for behavioral health providers. And so I wanted to plug our event notification service, NC Notify. Why? Because the state does not charge for any of our services. And with event notifications such as NC Notify, providers are given near real time updates of when their patients touch the health system outside of their practice and outside of their EHR. Because remember, all different provider types, all different EHRs, they're not necessarily communicating with each other. But with event notifications, providers can select what type of information they want to receive, as well as how frequent they want to be notified, and they can receive a panel to be that they can review it, and that way they can follow up with patients who may have went to the ED or went to an urgent care or hospital. And they can then make sure that the medications are reconciled. If they had a treatment that was conducted in the hospital, they won't necessarily repeat that. They can look at the medications, all the different things that they experience. They can see those exams, they can see those x-rays, right? Through the event notification panel. And that sits within our clinical portal, so they don't have to log into a separate system once they receive clinical portal credentials. If they've enrolled in this particular service, they'll also get their feed for NC Notify. So I wanted to plug that. And I have some testimonials and I'll share the slides, but I also want to make mention that on February 28th, we don't have to talk as fast, and we'll have expert from SAS coming to our teletown hall, as well as on March the 13th. If today's presentation made you even more confused and you have more questions, you can send us questions in advance for our office hours that's coming up on March the 13th. So I wanted to make sure I got that in, if nothing else, before ending. And my contact information is here So if
Great.
anyone wants to reach out, if I didn't answer your question today, I can definitely get back to you with a response.
Kenya, this is great. And I know it's how my brain works. I can't speak for others, but I know I've read information, I've heard it, I've heard you. I feel like I'm going to need to hear it a few more times. So
Again and
I don't
again
know
and
what it
again
is
and again
about
and again.
IT stuff that it just makes me like, and I know there's all these like qualifiers, like wait, but and I love the unidirectional and bidirectional and who can share what and what's private and what's not. I know that what I do know is that you are on I had a whole conversation with a colleague earlier the week, really the evolving, the vanguard of how we do business, right? We have to be able to have better ways to share our health information. People are wanting that with all the right privacy concerns, but we're wanting less fragmentation. I know it's 9 o'clock or 9:01. We didn't get a chance to go into it, but I do want to acknowledge you have shared in our conversations about your own, and you did a few minutes ago, that you are a caregiver as well. And so I just wanted to honor that and talk
Thank you.
about how your experiences you've shared with the group a little bit, but as we sign up, the North Carolina Serious Illness Coalition, how can we support your journey as a caregiver and your involvement with our caregiver group, which we'd love to have more of, as well as with the Health Information Exchange Authority? How can we work together more?
Yeah, y'all are doing it. I'm telling you, advocating for caregivers, especially those of us. I know I've talked to Karen a few times. Those of us who are full-time caregivers, when you're a person who doesn't have kids, oftentimes people don't realize, hey, I have full-time responsibilities as a caregiver. And when you are working a full-time jobs, just continuing to advocate that people, caregivers especially, are allowed to not only just, work and continue to do work ethically and integral in their positions, but to still when the opportunities come up, like we all do, we have illness. Not only, people don't think caregivers get sick, but not only do the people that we're taking care of have health issues, but we have our own things that we're dealing with, not only physically, but mentally, and emotionally. So just the having the opportunity and the space to share and advocate has been just priceless. And I appreciate all of you just for having been there, just as a professional organization and personally. Thank you so much.
All right. Well, thank you. I know there's a lot of more happening. Karen just shared, Kenny and I discussed the dream of having a caregiver information integrated into the EHR. And
Hmm.
Kenya, we're also going to do a shout out to your awesome partner, Luke Keeler, who's been answering questions and sharing information
Thank
on
you,
the chat line.
Luke.
Luke, thank you so much.
Yes, thank you so much. I
And
appreciate it so much.
questions about sharing information and if your organization is with Epic and shared. So anyway, there's a lot more we need to talk about. I can envision some great panels also, and please folks participate in the session on February 28th. But Kenya, thank you so much for coming on Friday Facts. You're getting lots of
Well,
love on the chat line here.
well, thank you so much, everybody, for having me, and have a wonderful weekend.
Thank you. Thank you all.